Sara. Don't go far because I think we have a panel discussion. And thank you, Sara. That was fantastic. We are going to proceed with the panel discussion and address some of the questions that were brought up online and any questions that may be brought up here as well. So please, I'd like to invite the panelists, Dr. Jackie Weinberg, Dr. José Pedro da Silva, Dr. Norm Silverman, Dr. Sara Trucco, and Dr. Tarek Alsaied, as well as Dr. Simone Pedro, who is a guest from Brazil, to join this section where we'll discuss, mostly focused on imaging and some of the presentations we have heard. And also, please feel free, the members of the panel, to ask questions yourself to each other, because I know that may also be the case that comes up. First, there is a question about the role of umbilical Doppler on fetal assessment of Epstein's anomalies. So, Jackie, if you'd like to comment on that, please.
I'd love to. As I talked about, the most severe complication that we see in fetuses with Epstein's anomaly is the development of a circular shunt. And again, the development of pulmonary insufficiency can be ominous, but a true circular shunt, to assess for steal from the systemic circulation in the fetus because of that pulmonary insufficiency and backwards flow in the ductal arch. The true assessment of the steal from the baby is with assessment of the arteries. In my mind, the easiest one to look for is the umbilical artery, because we assess that in every single fetus, whether they have cardiac disease or not, when we do a fetal echo. And when we Doppler the umbilical artery, you should see continuous antegrade flow throughout diastole. And in the one image, I showed a couple of images where you can see that normal pattern. And truly, when you see cessation of flow in diastole or reversal of flow, that is an indication that the flow is being stolen from that artery and going backwards through the right side of the fetal heart. Other assessments can be made with the middle cerebral artery Dopplers on the fetal brain, or in the fetal aorta distal to the ductal arch, if there's truly reversal of flow in the descending thoracic aorta at the level of the diaphragm or in the abdomen. That would also be an indication that the flow is being stolen from that systemic circulation. So it's an easy way to look for those very, the sort of worst case scenario for those babies.
Yes. I don't know, Simone, if you want to comment on anything, since you have a lot of experience in Sao Paulo.
Yes, I think another important feature is when you assess the RV regurgitation, there's a very low pressure. So those fetuses that have very low pressure, when you assess the TR, they are at risk for circular shunt. So I think this is a very important information too, besides everything that was talked here.
Yeah, wonderful. All right, the next question in the chat was specifically for Dr. Silverman. I think the question is not showing up in here, but there was a question about whether this is a mitral, something about this. Where did it go? I'm moving it. Oh, about the mitral valve and the tricuspid valve. It's disappeared. This mouse? Okay. The septal tricuspid leaflet and the anterior mitral valve leaflet share a common origin in the bridging embryonic leaflets. Yet, how often is the mitral leaflet affected? Do you think Epstein's is more of a leaflet or myocardial wall problem, or both? Is it a late post-embryonic issue, considering how often is the mitral valve effective in this structure? Is it a leaflet to wall interaction problem? Any thoughts on that, Dr. Silverman?
The mitral valve is, seems to be of little importance in my broad experience of Epstein's malformation. We know in tricuspid atresia that there's frequently abnormalities of the mitral valve. So I would suspect that there would be also some minor abnormalities in Epstein's, but I have not really
We don't see that.
found that to be a significant problem. The question of whether this is a valve abnormality or a myocardial problem is a very difficult one to resolve. I think both are involved. And Tarek, you showed some magnificent pictures of the septal dyskinesis that occurs in this condition. So the other thing about the left side of the heart is it's not normal, because the normal left side of the heart normally sees the right ventricle on the other side of it. But in Epstein's malformation, it sees the right atrium or the atrialized right ventricle. And so there is often a dysfunction on the right side of the heart, which I think is very much improved when you do a cone procedure on these patients and you put the valve back and also take care of that abnormal myocardium by doing an annuloplasty of the valve. So I think those are the important issues. The thing about whether the valve leaflets, the central fibrous body or the skeleton of the fibrous skeleton of the heart is uniform, but the septal leaflet of the tricuspid valve is only a small part of the problem. And I think I showed you this begins not in the embryo, in the fetus, after the formation of the tricuspid valve in its normal position. The valve leaflet is adherent to the underlying myocardium, and it's that makes it break down. As far as function is concerned, there is 15% from the Mayo Clinic's findings of spongy myocardium, or whatever you want to call it, hypertrabeculation, whatever, that occurs in Epstein's. And I think we showed you beautifully that this can occur in the fetus as well. And I think that the one thing about breaking the talks up like this is that this is really a condition that is a spectrum from the time of embryology all the way through postnatal development.
Absolutely. Yeah, it's beautiful. It's very true. Yeah, and hopefully.
May I comment? Yes, I think that's correct. Epstein normally involves the tragus valve and also the myocardium of the right ventricle. And secondarily, it can affect the left ventricle because the septum can be shifted to the left. And so the filling pressure, the volume of the left ventricle is decreased in diastole. So that also is an important issue. What we see in case where you have a good mobility of the anterior leaflet, then you have a good papillary muscle, usually, and in that case, that area of the right ventricle tends to be normal. When we have the linear attachment, and then usually the valve cannot have no inflow in the anterior area of the right ventricle, and the inflow occurs mostly near the outflow of the right ventricle. So those patients the heart does not enlarge much. So it's tough to say how bad is the right ventricle because it does not enlarge because the tragus valve tissues are holding together. So by looking, if we have tragus regurgitation, then the outflow tract of the right ventricle tends to dilate. And then it can get more dysfunctional, that area especially. And finally, by dilating the outflow of the right ventricle, you have functional pulmonary regurgitation. And that makes everything get even worse. So one thing that the cardiologist should look is the condition of the outflow tract of the right ventricle. If it's dilating, it's a bad sign. You have to intervene as quick as possible because the prognosis can be altered if that goes too far.
Wonderful. Thank you. Okay. Yeah, you want another comment or yeah?
I'll tell you what bothers me about the surgery of Epstein's is something that I don't understand. Maybe you can help all of us. When you do a cone or you do a stance procedure, which is closing off the tricuspid valve, the echocardiogram shows the right ventricle shrinks down in size dramatically. What is the physiology that causes the right ventricle to suddenly shrink down, or in, let's say, the stance procedure, or in well, a cone procedure?
I think with the cone procedure, sometimes initially you can have even a larger RV because you take down the anterior leaflet that is very tethered and the inferior leaflet too. So that area tend to bulge, tend to balloon. And that, so we do some maneuver to prevent that, but then sometimes, most of the time, they dilate. So they end up with a bigger RV in the beginning. But then later on, it tried to reverse remodeling in most cases. Now, regarding if the valve is well, is well repaired with no regurg, especially, and no pulmonary regurgitation too. So now, when you think in the Starn procedure, then what you do, you exclude the RV almost totally. You leave just a little hole of 4 millimeters. And so the inflow to the right ventricle is just 4 millimeters. So what happens is that the end diastolic pressure goes down. If it was like 12, it goes down to 3, 4. So the ventricle tends to shrink because of that. And then it does not generate pressure too much, much pressure, because the feeding pressure is very low. To generate pressure, then what you need is more feeding pressure, and the valve has to be competent. If you have, by doing the Starn, if the tricuspid valve come together and become more competent, then you can have less regurgitation, so you can generate some pressure more pressure, I would say, higher pressure, in the functional right ventricle. The other way to measure it, if you don't have any tricuspid valve competency, so you can look at that, at the hole in the patch, in the Starn patch. But that will be most of the time low pressure. So doesn't mean that the ventricle cannot be recovered. So that's why it makes it very difficult to indicate the operation after this time. I think we're going to have time to discuss that a little more, but evaluate the RV function after this time is very difficult.
Mm-hmm. Okay. Yes. There are some questions on MRI, Tarek, especially there's some questions about the correlation MRI and echo, and I know you commented on that, whether there is any cutoff of RV index and diastolic area on echo that you could use to correlate with RV and diastolic volume on MRI. That was one of them, and then some more about the role of MRI.
Yeah. Like oftentimes the challenge we have by echo is that we don't see the RV free wall very well in the port chamber in order to measure an accurate RV and diastolic area by echo. So that's why like in 50% we couldn't get the RV fractional area change in these patients. Mm-hmm. Generally speaking, we use an area below 35% by echo to determine dysfunction, and less than 45% by cardiac MRI for ejection fraction to determine dysfunction.
Wonderful.
Can I just ask one question of both the physiologists, the cath people, and the surgeons? Is how do you decide when to put a device in the atrial communication? Because we've had patients where we've done that, and the next morning the device is in the pulmonary artery, because basically the atrial septal defect or the communication is a pop-off valve, and when you need it, you need it. Of course, if you don't need it, it's easy to close. So what is the parameters of function that you use to find this indication to close or leave the defect open?
So is this on? In the cath lab, there's anatomic and physiologic parameters. So obviously you have to have enough tissue to hold on to a device so that embolization is less likely. But we test occluded and we see if the cardiac index drops and if the right atrial pressure increases significantly, then that's a contraindication towards closing it. If they have significant pulmonary hypertension, that's an indication for not closing it. And more times than not, now that we have the cone procedure as an option, if they have any indication for proceeding for surgery or a cone, we don't put a device in. We allow the surgeon to close it because they can either close it completely or at least make it smaller and fenestrate the defect if they do need a pop-off, but a smaller one so they're not as cyanotic.
Okay, thank you.
Yeah, one of the limitations, obviously, in the cath lab, it's very difficult to leave a small defect, right? We usually close it, and the surgeons can do that very nicely according to the results of the operation and figure out you can leave a pop-off. And sometimes those can close off on their own over time if they don't need them. But yeah, exactly what Sara said. Okay, wonderful. I think that one of the questions that I think Jackie was bringing up for Tarek, I don't know if you want to go ahead and ask, but there's some questions also in the chat about the role of MRI, whether we should develop some protocols for using MRI, since that appears to bring such valuable information that may actually play a role predicting outcomes longer term.
Yeah, so like before surgery, we always do a cardiac MRI if we can, and we do that in all adolescents and adults who don't need anesthesia. In smaller kids, we do it, on a selective basis, and if they are getting any other procedure that requires anesthesia, typically we go ahead and do the cardiac MRI, and we find that the information adds up to the echo information and can give some prognostic value later on for RV function in particular. Post-cone, we've been trying to do a cardiac MRI if they are local 1 year after the cone operation, and then periodically every 3 to 5 years, mainly to kind of like continue to follow up on the RV function and to evaluate the RV and RA size over time.
Wonderful. I think we're going to have to move on to the next session. But thank you very much to all the panelists, and some of the questions that we were not able to answer in the discussions, we will address online. So thank you.